All right, everyone. Thank you so much for joining us for our second expert panel speaker series. Today, our experts are going to talk about how to start an ICU early mobility program. With us today, we have Phillip Gonzalez, OT. We have Kaylee Dayton, Nurse Practitioner, and we have Katie Brito, PT. So we're kind of going to go through the 6 steps on how to start an ICU early mobility program from the PDF that can be found on my website. And we're going to kind of go through that for our talking points, and then we'll also go through some questions that you guys sent in throughout the week. And then if you have any questions, you can send it in the chat, and we'll answer the chat questions towards the end. And I'll let the speakers kind of introduce themselves and give more of their background. We'll start off with Phillip.
Hey everybody, my name is Phillip Gonzalez. I am an occupational therapist. I've been practicing for going on 11 years now, primarily in the ICU. I do have dabbled in inpatient rehab, outpatient hand therapy, but my passion really is in ICU. I currently serve as the Clinical Alliances Manager for Vital Go Systems, the manufacturer of the Total Lift Bed. I do still treat inpatient care. I am starting a new role as an adjunct professor at Bowling Green State University in Ohio. And really my goal and passion for ICU is really working to develop the foundational knowledge that OTs truly are lacking in school and need to be able to practice successfully, confidently, and competently in the ICU. So I'll hand it over to Kaylee.
Okay, we're playing popcorn. I'm
Yeah.
Kaylee Dayton. I'm a nurse practitioner. I have 7 years of experience in an Awake Walking ICU, 3 years of experience in 10 other normal ICUs, and I have done over 200 podcast episodes dedicated to sedation, delirium, and mobility management in the ICU, and I've now trained 15 teams to become Awake and Walking ICUs. Hand it over to Katie.
Really hard to follow both of you on that. I'm Katie Brito. I am a board certified cardiovascular and pulmonary clinical specialist. I also am an item writer for the board specialty exam. I serve as an education coordinator. I still do clinical practice, but I'm split 50-50. So I do 20 hours of clinical practice throughout the hospital. And then I do 20 hours of admin where I'm an education coordinator. I support staff development, onboarding, competencies, skill development, process and quality improvement projects and research for the Northwestern Medicine System here in the Chicagoland area. I also serve as an adjunct professor at Graceland University in Kansas City, which is a hybrid PT program, while my practice before I switched roles was predominantly in the ICU, working with patients on ventilators and getting them up and moving. It's nice to be in this educator role and kind of help foster the next generation.
Thank you all so much. So we're gonna start off with step 1 on how to start an ICU early mobility program, which is presenting to the rehab department leaders. And we're gonna have Phillip kind of start off going down why that's so important and what that presentation should include when you're pitching to your managers, your supervisors, going to your department about why you want to start a program like this.
No, absolutely. So I think for me, a little additional background. So I've worked all across the state of Texas, both as full-time as a traveler therapist, as well as in Florida. And one thing that I've noticed across the multiple hospitals that I have worked in is anytime you're stepping into an ICU as a clinician to treat patients, you also need to step into an ICU and look for barriers and opportunities for improvement. The ICU is a constantly changing environment, not only for patient care, but interdisciplinary team dynamics too. And so I think that's one thing we as therapists are very unique at having the ability to see is the team dynamics from all the different units, as well as sometimes follow those patients when they step down from the unit. So anytime we're working to present leadership with building a more robust early mobility program, the first thing that I always like to focus in is looking at identifying what the barriers are. Even if it's just preemptive work, maybe some inklings of, hey, I've noticed this little step could be better, or we have opportunities where I think some of our therapists may be lacking competencies on some vent stuff. Identifying what those barriers are so that you can really be able to speak to them when presenting to your leadership. But not just present the barriers in that moment. You also want to present solutions. Because one thing rehab managers really tend to get bombarded with are all the problems some units have, some therapists have, some patients have. But oftentimes what we need to do better as clinicians, as subordinates, as staff therapists, are if we're presenting a problem, we can't just present the problem. We have to present the solution. And what do those barriers look like, and what do those solutions look like? How are you tracking them? Being in more of a leadership role and management role now, and on this side of things, I often see that yes, we want the absolute best 100% compliance for all of our patients, but there are some things that are just limited from a logistics standpoint. Has to be able to be tracked. Okay, so are we meeting our plan of cares? What are our opportunities to help build those barriers or alleviate those barriers? And what's going to be the observable metric that we're going to track? Is it going to be plan of cares, pressure injuries, ABCDEF bundle compliance, treatments? Are we looking at the days in the ICU? What are we looking to track our success? And then the other thing is identifying productivity. That's going to be a big topic that we're probably going to talk about throughout this entire live stream is how do we mitigate some of our productivity with implementing some of these opportunities, because one's going to have to take a hit. And I think we're going to talk about it a little bit more, but I want you guys to keep that at the front of your mind. And then finally, the other thing is the clinicians that are going into the ICU. Like I said earlier, one of my biggest foundations is talking about competency and confidence in the ICU. Is what does that competency and confidence look like? So when you're presenting to your rehab leadership, you never want to disparage the clinicians that are in the ICU, the nurses or the therapists that are already there, but we also want to make sure that we offer them opportunities to advance their skills. So some of my favorite things that we look to see what the attitude is in the ICU, the Johns Hopkins ICU Mobility Beliefs and Attitude Survey. I think that's a phenomenal tool to kind of just gauge what the culture is and have on paper what those sentiments are. The Permi ICU competency checklist. Yes, it's a competence checklist, but I love to use it as a self-assessment. It's one way that it can be almost as a low-key, like, hey, I'm going to go through this and see what I don't know so that I don't have to, so that I know what I need to study so that I can be prepared if anybody asks me, but you don't have to publish it to everybody. And then also one thing too is clinician motivation. I think we've all been there in facilities where there's some clinicians that love the ICU, they're great in the ICU, and then there's some clinicians that are just told they have to go to the ICU. And sometimes those mobility programs are going to look a little bit different.
Thanks, Philip. That's great. And what's also nice is you can kind of use the same presentation for when you're presenting to the rehab department leaders and when you're presenting to the nursing, RT, medicine leaders, is you really just need one presentation, and you can use that same presentation for everyone. And having statistics is really important, pulling statistics from other hospitals that already have implemented an early mobility program and have the data to show that not only is it beneficial for the patient, but it's also beneficial for the hospital. The hospital saves all this money. It helps with reducing nurse injuries, staff burnout. There's all this research out there, and hospitals like to see how is it going to help us, So having statistics of, yes, it helps the patient, but it also helps the hospital. So that was great, Philip. Thank you. And then Katie's now going to go a little bit more into the role of rehab leader specifically, your rehab manager, supervisor, leads, the rehab educators, kind of what is their role when it comes to wanting to start this type of program?
Yeah, so, it is an interprofessional effort all the way around. You talked about involving nursing leadership, you have to involve physician leadership and the ones who are actually going to be managing the care of these patients. But when it comes to rehab leaders, it can go a couple different ways. And, when we want to speak to the most ideal scenario, those managers who are super motivated, super excited to want to be on the cutting edge of evidence-based practice, want, patients and families raving about, the successes. We're looking at ICUs that have lead designated therapists, therapists that are not only competent, but your lead designated therapists have to be someone who's either proficient or an expert, who's taking lots of coursework outside of the hospital, outside of different vendors that offer CEU courses. They're going to in-person courses. They're taking a variety of courses. I know we've talked about before, there's a lot of great either conferences or coursework out there. Of course, we talk about PERMI, ICU Rehab Seminars, offers great foundational coursework for people to, definitely get started as well as more advanced. Johns Hopkins offers a critical care rehab conference, which also has a variety of tracks and tiers, either both for adult, more advanced individuals, and also for pediatrics. And they cover, nursing, PT, OT, speech, as well as physicians at those conferences. Henry Ford has also run a critical care rehab conference for the last 7 or 8 years, I believe. So that's an option for people, in the Midwest that might have a harder time with traveling. But, it takes a champion. A lot of times we call them floor champions, to really embolden these philosophies, as well as to manage consistency. So increasing mobility in the ICU does take a certain amount of frequency. It does take consistency, as well as competence, but also confidence. We don't want someone to be overconfident in the ICU. There's always a healthy amount of fear, we call it, that allows you to kind of be aware and constantly assess the patient response, surroundings, and what's the best way to dose activity. And those are things that can't really be taught in a timed schedule, for competency. Where a rehab manager comes into the play is the support for their clinicians. So whether it's in these interprofessional meetings with other leadership, going to bat for their clinicians, supporting their clinicians, finding ways to get hospital leadership to support coverage for CEUs in order to better themselves and improve things, because you do, as much as there's a lot of great asynchronous offerings or virtual offerings, it is important to get in person for some of this coursework so you can actually interface and interact with other clinicians across the country, as well as those leaders who might be presenting and instructing. For educators like myself, it's designing realistic but evidence-based competency programs that are both sustainable and scalable to help program growth. And I'll talk a little bit more about competencies, later on, but it is a team-based environment. So if you are looking to start a program, one of the things I would recommend is find that nursing champion, find that physician champion. If you're a PT, grab your OT and speech colleagues, and all of you guys kind of do a group rate and register for some of these conferences, because you guys are all then going through the coursework, interacting, discussing with each other, and learning together. Adult learning needs to be self-directed in order for it to be sustainable and effective. And one of the things that works really well with adults is when you're learning in a group and you can interact and you can discuss and just kind of build off of each other in that learning environment. Culture, and from there, culture change management is always challenging, no matter what. Especially if you're dealing with, a really either toxic or really reserved culture. And so patience is one of the biggest things as well. I get it. I was a very young, excited go-to clinician when I started way back when. My hospital had no experience with mobilizing patients on vents. I did as a student on rotation, so I had the experience. I was the one bringing it in to the hospital when I was hired, and while I was like ready to go off my rotation right off the bat, it took time to build those relationships with nursing staff, get them to trust me, understand my background, my knowledge, my skill set, both from what I would tell them and what they would observe from me, as well as with the physicians. So I started in 2018 at my hospital. It took until about December 2019 to get to a point where they would be behind it and supportive of it. And sure enough, a couple months later, we had a pandemic, frontline. I didn't leave the ICU, and we went from maybe having 1 or 2 vents in the ICU to 19 to 20, and I had to quickly scale up how to get the rest of the staff relatively competent and comfortable with seeing patients on ventilators, because what wasn't scalable was that I couldn't see all those patients by myself, and I wasn't there 7 days a week. So there's the, you know, ideal evidence practice and what's in the literature, and you have to build to that. It takes time. This is not a 1 year, 2 year project. It does take time to get enough people trained, comfortable, competent, in order, and also to make it sustainable, because as
Totally.
you guys are mentioning, turnover happens.
Yes. And another big point that people bring up in terms of competency for the ICU is being competent in one patient population does not necessarily mean being competent in all of ICU, right? As we know, there's a lot of times where there's step down patients being boarded in the ICU, med surg patients, telemetry patients being boarded in the ICU, where their physical location is in the ICU, but they're not necessarily a critical patient. Or even if they are a critical patient, a DKA insulin drip on versus an ECMO patient is very different competency. You know, same with like even a standard open heart patient. Like that's a basic ICU patient compared to like an Impella. So I think having like a tiered system of competency where, you know, you might get one ECMO patient a month, and it's not fair to say this therapist is not allowed to go into the ICU because they're not competent in ECMO yet, when they've become competent in everything else. So kind of having this tiered system, kind of modeling the nursing model where nurses, you know, just because you're an ICU nurse doesn't mean you can admit every single type of patient, doesn't mean you can take every type of device. You have to go through tiers of competency. And I think this is where we hit a lot of pushback sometimes from nurses and RTs, is that nursing has a very structured system of training of, you know, everyone knows which nurses can take which patients. It's very clear, it's very allowed, it's like written out. And I feel like when we are sending therapists who maybe are not trained to see an intubated patient, but they're trained to see an awake, fresh open heart or a DKA or an EVD, and they're going in and they're trying to see ventilated patients, and it's creating some tension with nursing, and it's giving the perception that rehab is sending untrained therapists, which kind of sets you back even more. So to allow people to come into the ICU, I think, like Katie mentioned, it's important to have a system of knowing who's trained in what, who's allowed to see what, so that it's still fair. Everyone can come in, but you're only seeing what you're trained to see and not taking unnecessary risks. That was great, Katie. Thank you so much. Now, Kaylee's going to go a little bit more into the elements of an early mobility program, including like medically appropriate criteria, nursing, screening tools, rehab. I'll let Kaylee take it away.
And before we even get to that stuff, I think it's important to recognize that mobility is like a fruit of a tree. And we keep on trying to grow this fruit, but we are neglecting the roots and the trunk of the tree. And so we have to first establish things like what Phillip talked about, is a survey to understand what are the beliefs, what are the knowledge, what are the perceptions of the bedside clinicians, and then build those roots. We have to build that knowledge, perspective, skill sets, culture, workflow, protocols, to then be able to grow the kind of fruit that you're wanting to establish. I have found that most teams are like, yeah, we know about delirium, we know about ICU acquired weakness. We know about it. That's fine. We got it, especially physicians. Yeah, like I learned about that one time. And we see it all the time, so like we get it. But when I train teams, I say, nope, everyone's gonna pause. We're gonna do 4 webinars and we're gonna go deep into this. And they're really shocked by the statistics, actually hearing survivors, really learning what this means in examples of case studies, seeing the big picture, like when you really almost like put their faces to the fire hydrant and make them understand the reality and the risks and repercussions of what they perceive as safe and normal in terms of sedation and immobility and being in bed. It helps reframe early mobility as something that's a back-end rehabilitation tool that comes with high risks and only certain patients maybe kind of sort of can eventually do it, to what we're currently doing is really dangerous and high risk, and most of our patients should be mobilized. So you have to lay that foundation of making sure that every single member of the team knows the why. And you want to have a culture in which people are more afraid of delirium and ICU-acquired weakness than they are of falls and self-extubations. Then you can really start cooking, right? Then everyone's actually open to learning something more. There's also a perception of, we already do this. We do early mobility. Sorry, I don't mean to laugh. I hear it all the time. Every time I go to train a team, they're like, yeah. PT and OT come. We're friends with them. We're good. And PT and OTs are like, yeah, but we can only really Hoyer trach patients to the chair by the time that we get in there. And so we also have to make sure that everyone understands things like what sedation actually does to the brain and to the muscles. That mechanical ventilation is not an indication for sedation. That awakening trials are not just for breathing trials, that we should be taking sedation off shortly after intubation so that to see if a patient actually needs sedation. And then they have to understand what we do instead of sedation. So that's all part of the why, this foundational piece. And then everyone, like Katie mentioned, being able to do an interactive, combined all the disciplines together way to actually practice and learn together and work through some of our politics, some of our workflow issues. Like there's a lot of stuff that happens consistently that we kind of mutter about passive aggressively on the unit and roll our eyes at, but we need a safe environment in which we can actually put it on the table, sift it out as a team. But that's best done when everyone understands the vision. When I talk about Awake Walking ICUs, to me, it's like a big jigsaw puzzle. And there are so many different pieces to that puzzle. And a lot of teams have a lot of the pieces. Oftentimes they're missing key pieces and they don't even realize it because the general problem is they don't see the front of the box. They don't see the big picture that they're trying to build. And so it's really hard to plug in competent PTs and certain protocols and parameters when we don't know what we're actually building or what it actually takes to get there, what the front of the box looks like. So once everyone knows what that big picture is looking like, then they start to collaborate to put the pieces together and be more efficient with it. And then they have to know the how. So they need to know who actually requires sedation, who to turn it off on, when to turn it off, how to turn it off. So we're always like, hey, do an awakening trial. I was just doing a symposium with a team, and I asked the PTs and OTs, do you participate in awakening trials? And their eyes got really big, and they're like as if like it had never crossed their mind to be there when sedation goes off. And yet here we are saying, well, nurses just won't turn sedation off, but we don't know how to as a team when we leave it to the nurses. So that's the kind of stuff we have to work through is how do we approach turning sedation off? Preferably it's shortly after intubation, so it's much easier for patients to be able to communicate, easier to manage the ventilator. You don't have as much delirium and weakness going. And then when you set it up correctly that way, it's much easier to mobilize patients. Historically, with mobility being like a late intervention, now you need a lot more people and a lot more skilled hands to mobilize patients that are so profoundly weak and confused and impulsive and have inadequate respiratory muscles. It takes a lot more. And so that's really going to be hard if you're trying to implement an early mobility program and you're not approaching sedation as one of your first key interventions, because then it's always PT and OT asking the nurse to turn sedation off, asking the nurse if it's okay, asking, like trying to just get them off the sedation, get their eyes open, and then try to mobilize them. It will always be a huge challenge. And if that's where you're at, then establishing, we as PTs and OTs, we are here to help with those awakening trials. And we're going to try to stick our nose in and say, hey, it's time to take sedation off. And if not, why? We're going to ask why. And when I mentioned that to these PTs and OTs at the symposium, their eyes got even bigger. I think they were like, oh my gosh, I'm going to get my tires slashed, right?
Yes, and I think
the infamous stay in your lane.
Yes, the infamous stay in your lane. I was just going to say, and I think it's a great point that Kaylee brings up of this is why, back to step one of, it's so important to set program goals of what is the goal of the program. And if you set a goal, for example, all patients have a PT and OT consult within 24 hours or are seen within 24 hours of intubation, then you have something to track. And like she mentioned, you can't practice the E without the A, B, C, D, and F components of the bundle, right? So if you're saying your goal is that all patients are going to be seen by PT or OT within 24 hours after admission, after intubation, then you have to have them awake, because in order to meet that goal, the patient, so it kind of, by setting program goals, not just for the E, but for all components of the bundle, that is kind of how you keep yourself accountable, right? If your unit is saying, yeah, we do early mobility, like all of our patients get up, we'll kind of get to, or we had this in step one of looking into your hospital statistics and tracking it, checking to see let's track our early mobility documentation, same way we track CLAPSI, CODI, all of that, checking and seeing and finding out, oh, we actually are not doing early mobility. We're waiting until like day 8 of ICU admission. So like Kaylee mentioned, it's great to have goals that you can track. And specifically, another really important component of the early mobility program is making sure you have a medically appropriate criteria that's specific for your unit. And the reason that matters is what a transplant academic hospital's early mobility criteria is going to be, and what a small standalone community hospital's early mobility criteria is going to be. If you have one intensivist for 30 people, you don't have safe nursing ratios. You're in a state like Oklahoma, for example, where there's no nurse protection for ICU nurse ratios, and both charge nurse and the primary nurse have 3 to 4 patients, and you have one PT covering 4 floors, you're probably not going to be able to mobilize someone on 100% FiO2. But if you're in an academic hospital where every 5 feet there's a physician sitting, and you have one-on-one nursing ratios and your patients are awaiting transplant, your medically appropriate criteria might be very different, because it's all based on risk calculation. How much of a risk are you able to take based on the circumstances you're in? So Kaylee will go a little bit more into the medical appropriateness and kind of how you decide all of that.
Yes, and when I hear about these situations in which they have 3 patients to 1 nurse, obviously we all agree, no questions asked, that is absolutely inappropriate and unsafe.
Or 3 CRRT patients.
Huh?
Or 3 CRRT patients.
3R, yeah. I mean, it's just, it's insane. And so, yes, there's like, this is not, absolutely not feasible. So this is how to start an early mobility program. This is why you go to your hospital administration and you say, what we are currently doing is extremely expensive. And so the way I do it is I have teams go out and do a manual audit and show their actual sedation practices, not just what's charted as far as RASS scores, but what is actually happening at the bedside, how much delirium is captured in that window of auditing, looking at their length of stay, time in the ventilator. Johns Hopkins has a financial calculator showing the ROI of an early mobility program. So I think that's one of the key pieces to start with, is having hospital administration understanding how expensive current practices are, so that this is not the scenario. So that we say we cannot afford to have 3-on-1 for nurses. We can't afford to have PT and OT just barely visiting the ICU. This is how we establish them in the ICU part of the team. Otherwise, this is expensive. We're sending patients to the acute care floor who we set up to go to nursing homes, and now they're going to sit and rot in the acute care floor, waiting to go to rot to the nursing homes, and they're just going to come back to the hospital. So we have to paint that huge, big picture. I'll share with you guys a Nurse Leader article where I pulled in a lot of the research to paint that picture for the executive nurse leaders. That's the kind of conversation we have to have. And so when it comes to a community hospital, if they're not able to mobilize intubated patients, then they probably shouldn't be taking those patients. Like, this should be part of our triage when we look at telemedicine. Having worked in telemedicine, if, especially certain COVID patients, I'm like, if they are really scared to mobilize patients and not able to do so safely, then that's probably a trigger to transfer to a facility that is capable of that. I've received lots of patients from community hospitals where they have done a lot of damage with sedation prior to. So We need to look at, again, making sure that they have the proper ratios, that they are properly staffed with RTs as well. And then again, looking at that criteria. So yes, we are always looking at criteria in the lower level hospitals, right? Having worked in a tertiary hospital, we got patients with increasing acuity all the time. So if that needs to be part of our triage is, are we safe to continue to provide safe care for these patients? And safe care includes the ABCDEF bundle. It includes early mobility. If we cannot continue to provide that care, we need to send them to somewhere that can.
Absolutely.
Now,
And go ahead.
even if our big academic hospitals, though, sometimes our parameters and our guidelines are so conservative that we actually increase the risks. Like I see in some of our big hospitals that they will not allow mobility above a PEEP of 8 or 10 and FiO2 60%. And I think, and they're trying to be safe about it, but I'm like, what's safe about keeping our ARDS patients deeply sedated and down for 3 weeks before trying to mobilize them? And mobility is part of ventilator weaning. So are we really going to achieve those goals in a safe, timely manner? So when you're looking at your guidelines and parameters for mobility, obviously there needs to be safety checks, right? The femoral sheath, that's a no-go, right? But allow for enough flexibility that provides and facilitates critical thinking.
Yes, and I love the point about flexibility, because sometimes we have, so at certain facilities, they have intensivist override of certain criteria, where if that criteria is not met, if let's say your criteria is 80%, but the patient's on 90%, and the intensivist wants to override that criteria, that's fine, but the intensivist probably needs to stay, or a nurse practitioner or PA, or if any sort of, so this criteria is kind of like a guideline. It's not like a end all be all hard stop. This is kind of what guides decision making, but at the end of the day, the ordering provider is the person that has the final call. It is a interdisciplinary collaborative decision, but you know, especially if you're in a transplant facility where mobility is life and death, sometimes it is the decider between getting an organ and losing your spot on the list. And in that situation, withholding mobility for someone on 100% FiO2, who's going to be on 100% FiO2 for weeks and weeks and weeks, is a life or death decision that you're making. And so having that in mind, that the physician is allowed to override certain criteria, and having that discussion of saying, okay, you know, this is a pretty intense criteria you're overriding. I would like for you as the intensivist to stay present, at least for the beginning portion, kind of making sure you're still doing things in a safe way. And a little bit more on the role of the intensivist is having a mobility order set, because a lot of times we hear that, you know, RTs don't want to make vent changes during mobility, or RTs don't want to help during mobility, or a lot of just pushback from the respiratory therapy department, which from their perspective is there isn't content about this in RT school. There are no RT guidelines on what to do with the vent, how to do it. There's nothing in writing that says you have to help PT and OT mobilize. And so it becomes kind of like a liability thing for the RTs. And they have really strongly requested that there's an order that says, okay for RT to assist with mobility. And to PT and OT, that kind of does sound a little bit silly. But from the perspective of an RT, when there is nothing else in writing anywhere that says they're allowed to, they can, they should, that sense of responsibility they feel over the integrity of the ET tube is huge. You know, that's like the patient's lifeline. So some hospitals that have very, very strong early mobility programs, the intensivists have a specific ventilator mobility order set, which is a PT order, an OT order, a vent management order specific to activity. So all intubated patients get like the adult mechanical ventilation order. And depending on your facility, the standard order usually says like, okay for RT to optimize vent settings within control mode, for example. So having a separate one for activity that says, okay for RT to make ventilator changes PRN during activity. And then depending on the intensivist, if they're okay with the RT going from a control mode to a spontaneous mode, or if they only want the RT to play around in control mode, kind of specifying that, like what exactly is the intensivist okay with the RT doing with the ventilator.
But then you also like need to have like hospital policies and protocols, because you don't, I mean, it's good for intensivists to be able to write customized orders, but you also don't want it to depend on which intensivist if you're creating a high reliability environment, because some intensivists are like very old school, very, they want full control of the ventilator. And maybe in some environments, that's better because RTs don't have the expertise or the experience to be fully autonomous. But the end goal, you want RTs to be practicing at the top of their scope. So I think, like I trained at a hospital where they had no RT-led protocols as far as SBTs or mobility. They had to go to the physician for all adjustments, or at least get certain things signed off every time they made an adjustment. Then the next level would be let the intensivist override it. But the next level is have it in your hospital policies and protocols that SBTs are RT-led, that mobility is RT-led, that they have like scaffolding for safe parameters, but they are using their own autonomy and critical thinking. But then that also requires the RTs have the education and support to be able to practice at that level, which, just like Katie talked about, like this mentorship process and creating PTs and OTs that are competent in this way. RTs do that as well. So you need to know where your RTs are at if they're prepared that way.
Absolutely. And depending on your site, sorry, I didn't mean to cut in, but you know, to your point, you know, it is also on the rehab discipline. So PT and OT, and especially PT, because there is a broad scope. Speaking of someone who's a cardiovascular and pulmonary clinical specialist, there's a broad scope and a very deep understanding of vents and physiology of the lungs with exercise and activity. So in the early stages of the program, especially when you're still trying to, you know, maybe address some of those hospital bylaws or get RT comfortable with these things, leaning on that expert therapist that has that background and understanding to discuss with the intensivist. This is what I noticed when we tried this. This is what might actually improve patient outcome during the session in terms of like vent settings and adjustments. And I know I've done talks on that before at CSM. I know a variety of other clinicians who have done talks on that at CSM. You know, PTs, we got to remember, you know, our background, our origin story is acute care, hospital therapists. We were the OG, you know, helping manage all of these things back in the day. And in other countries, you know, it's physiotherapists doing this. So
we're the same as RT in other countries.
We need to partner with our RT colleagues and be their backup. Just like PT and OT have overlap in the hospital, we overlap with RT, and we need to be their backup and support both their education and competence in this area, but also as that, you know, person to speak up for them when they say they're thinking this. We're like, nope, we agree. We have that background in education. We totally agree with this recommendation and change.
But that also puts a lot of pressures on the rehab department as things stand right now, because, I mean, for example, just the symposium I went to and was running, these are a lot of ICU clinicians or ICU therapists or therapists that have been in the ICU that are like, yeah, we got this. We're just waiting for nurses to let us do our thing. And then when I ask them about ventilator management or ventilator modes or settings, we don't know, but that's not our thing. So yes, I would love, I mean, I know certain physical therapists who have trained the RTs to do the RT thing during mobility, but most PTs and OTs are not prepared to have that discussion. So when I train teams, I actually give the RT department curriculum and say, this is what I want you to have a whole session and training course with your therapist on airway management, ventilator modes, settings, worst case scenario stuff, because they don't know that. And yet these are oftentimes the therapists that are like, oh yeah, we do ICU, we're fine, everyone's good to work in the ICU, but they don't actually know those things. And so I think there's a lot of cross training that needs to happen, as well as from rehab to the nurses and nurses to the rehab as well.
Yeah, so that actually is a great point that Philip's going to talk about in a little bit, of the interdisciplinary collaboration. You know, a huge part of this page, Critical Care Rehab, is that emphasizing RT is our therapy cousins. You know, Physical therapy, occupational therapy, speech therapy, respiratory therapy, like they are a therapeutic profession. And the same way we collaborate with OT and we collaborate with speech and we have overlap, we also have so much overlap with respiratory therapy. And like Katie said, our origin story is we started off in the hospital in acute care settings. And in most countries, PT and RT and OT are all the same profession. You know, you have one therapist for all three of those things that intubates, gets them up, walks with them, takes them to the bathroom. Like we're all very intertwined together. And so a huge part of having a successful ICU early mobility program is the interdisciplinary team collaboration. And Philip's going to kind of go into detail about how we can all help each other throughout this process.
Yeah, no, absolutely. So I think one of the highlights to this whole conversation, I think that everybody has touched on a little bit, is that interdisciplinary team collaboration, but also the lack of knowledge and some of the opportunities our professional colleagues have with truly understanding the breadth of scope of practice each of our disciplines have. Now, I don't mean to say like I need to know everything that's in RT scope of practice or I need to know everything that's in PT scope of practice, but just have that understanding that when each discipline is practicing at the highest level of their scope of practice, there is going to be that overlap, and that is okay. I have a perfect example that actually ties into our whole conversation with RTs. I was consulting with Kaylee at a facility one time, and we were doing night classes and training, and I was just having a one-on-one discussion with an RT, which they knew I was there, but they had no idea what my profession was. And Kaylee's smiling and laughing because it was funny the reaction this person had, but we were talking about vent modes and talking about different appropriateness of when to make changes, how to make changes, things to consider. And RT was like, yeah, super agree, everything. And then I turned the conversation around and I said, yeah, for me as a OT, I sometimes don't think of the vent any different than I would a walker or a cane or a mobility device. And I'm going to titrate that mobility device to the activity that I'm doing. And the clinician asked, they're like, wait, what profession are you? I said, I'm an occupational therapist. They're like, how do you know so much about the vent? And it's because of that interdisciplinary teamwork and my years of experience in working with different hospitals that I really had to advance my skills to be able to speak confidently and competently about these topics. But it was just funny seeing that because it's also eye-catching that sometimes these other disciplines don't really know the full breadth of our scope of practice. And that goes into where we have opportunities for self-advocacy within our units. Of course, being the OT, we're often the stepchild of PT and OT. Sometimes, especially old school PTs, along about 10, 15 years ago, OTs weren't really well received in walking patients. OTs weren't really well received in mobilizing patients to certain degrees. So I've fought that battle from the very start of my career. And the way I did it, I don't want to say kill them with kindness, but I really wanted to advocate and introduce, this is what my goals are. I'm not trying to overstep and do your job. I'm trying to do my job, incorporating the gray areas of how all of our scopes overlap. And so that brings us to rounding. I know rounding is a varied topic, and there's varied degrees of rounding at all the different facilities we can practice at. Some rounds they do flash rounds where it's like, oh, quick 15 minutes. We're just going to go boom, 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 talk about every patient. Some ICU rounds can go up to 2 hours. And so that's often a question that I always get is, what do rounds look like at the various hospitals that you've worked at or that you're consulting with? And how can we improve upon that? Because all of us are held to productivity standards. RTs have their own productivity standards, which makes it difficult for them to sometimes work with patients on the vent, especially if they're being called to ambulate a patient with PT or with OT. That takes away from all the other productivity metrics they need to get. PT and OT, if we're seeing a highly complex patient that may be on CRRT, the vent and ECMO, and we need that other discipline, that's going to take maybe an hour and a half of setup, intervention, and then putting them back where they need to be versus a standard ICU patient cabbage where we know the routine, we're going to get everything organized really quick. We can be in and out in 45 minutes, 30 to 45 minutes. But that takes away productivity from their other patients. Rounding itself takes away productivity and it's non-billable time. So what do rounds look like? First and foremost, when I first started, especially in the ICU, I had to show my worth. I had to show what I knew, what I wanted to accomplish, and what goals I had for my patients. And I almost kind of initiated my own rounding. Walked right up to the physicians, introduced myself with my manager's blessing, introduced myself, went through the list. I would sometimes pre-screen my ICU patients. They either had PT orders and maybe not an OT order, or just go through the whole list if I was in a smaller ICU and just say, hey, yes, no, yes, no, yes, no. We do have that ability to screen patients that are in our hospital facility within reason, especially if there is concern for a mobility our mobility deficiency where they're going to have needs for PT and OT in the future. And then presenting it to the doctors and say, hey, I have concerns about this patient, this patient, this patient. This patient has had PT orders for 3 days. They're missing OT orders. This is why they would need them simultaneously. Let's get that order set implemented so that there's a gap. Sometimes it can be as simple as when doctors, especially in small community hospitals, are ordering PT, they think that the order automatically goes to OT as well. It can be that simple as identifying that barrier or that opportunity. Sometimes it can be just a lack of knowledge. Oh, I didn't realize we had OTs in the facility that could see my patient, so I didn't put in that order. Just letting them know, hey, we're here. We're here to support you. We're here to assist you. And then really leaning on our colleagues. So SLP and PT are often in the ICUs very frequently as well. They can keep eyes and ears out open for us, especially if PTs or our OTs are missing opportunities in the ICU
And I think
to
this
really
goes
help
to the
advance our plan of
point of,
care.
sorry to interrupt, Philip, but this
No,
goes
go
to the
ahead.
point of having a mobility order set for the
Yeah,
intensivist of, you know, proving, like Philip said, we know what we know. We know our worth. We know our limitations. And we're not going to see someone if we're not comfortable seeing someone. If someone's not appropriate, like having that trust with your medical team, like
yeah,
that the goal is for every patient in the unit to have a PT and OT order, and we decide who's appropriate and who's not appropriate.
Is
And
it though? Like, do every single patient have a PT and OT order? Like,
I will say for at least for starting off an early mobility
yeah,
program, it does eliminate the problem of waiting days and days, and
yeah,
it eliminates the problem of only getting PT consults and not OT consults, at least in
okay.
the
yeah,
beginning when the physicians are still learning who's appropriate, who's not appropriate.
Yeah.
And it's just it gets very overwhelming of they have so much going on that a huge feedback we've gotten from the intensivist is, can you just decide who to see? Is that okay?
Yeah.
And starting off, I think that's a great way of eliminating the problem of OT always getting left out or days
yeah,
going by before a patient gets consult orders, is
Yeah.
as soon as you put in your ICU admission set, click the mobility order set, and then in rounds, PT and OT can talk about why a patient's not appropriate or why they are appropriate, or we can talk about those nitty-gritty details in rounds, but at least every patient has the order there.
An option.
Yeah.
Yeah. Long term, like it's just a lot of time for you guys to have to do a chart review,
yeah,
figure out what's appropriate. So we want to create an environment in the end in which every single member of the team is thinking about mobility, thinking about sedation, thinking about getting them up, and we reserve your time for the patients that need it the most. That not every
yeah,
single patient
Yes.
is going to need you
Totally.
guys, but if your nurses are not mobilizing patients, then every single patient needs you guys. But we want to create an environment in which it's not just you guys mobilizing patients. It's
Absolutely.
nurses, NAs,
Yeah.
it's the mobility techs, whoever is there. But that's a huge gap right now, is that though it's in the nursing scope of practice, it's not in the nurse's education, skill set, auditing process to be screening for mobility and executing mobility. There's like the nurse's brain that shows up in the EHR does not show mobility as just as important as medications and lab draws and procedure. That doesn't show up. And so right now, and there's no like standardized expectation for in a lot of ICUs. So when I worked in Awake Walking ICUs as a nurse, we treat it like an antibiotic. If I didn't mobilize my patient at night without PT or OT there, I was in trouble. MPs would come in at 6:50 in the morning as I'm ending my shift, and they're like, your patient's still alive. Why didn't they get mobilized last night? What's your excuse? And so that's how we better utilize our PTs and OTs, is by everyone doing it, and then they could really hone in on the patients that really needed them. All the patients
Absolutely.
didn't co-treat. So we got a lot more sessions in and utilized
Yeah.
their time.
And I think that's why it's so important for there to be interdisciplinary collaboration of having PT and OT doing skills checks and training for the nurses on mobility. A huge thing we hear from nurses is, I just don't know how. I don't know what to use. I don't know how far the patient can get with mobility. And unfortunately, it's again very dependent on your nursing school, your training, your unit training, what's available. And so having a routine quarterly, maybe twice a year, where the PTs and OTs do like an in-service or a mobility skills lab for the nurses and for the RTs on equipment demo, hands-on practice, what things to use, and then implementing like a nursing mobility screening algorithm, again, depending on your state, depending on your staffing ratios, depending on your availability. There's plenty out there. The modified egress test, which is posted on my website, talks about kind of how if you're in an environment of limited resources, how do you decide if the patient's safe to mobilize with nursing, or if this is a patient that you should maybe wait for PT and OT if you're not sure. And then also about the competency, like Kaylee mentioned, not every therapist is fully competent on ventilators and airways, and kind of there might be some hesitation for therapists on how comfortable they feel because of that unfamiliarity. And budgets, money, that always comes into play of, oh, we can't pay to train all of you guys, we can't pay for all these courses. Well, RT, if in your, RT and nurses are very smart. They could do their own in-service for PT and OT, talking like things that is very basic to an RT is very basic to a nurse. Having them do a skills lab and an in-service for the therapy departments on this is what an EVD is, or this is what a ventilator is, and kind of teaching each other and collaborating in that way. And Kaylee, you brought up a great point, which is our last point for wrapping things up is, you said the nurse practitioners would check and see, why isn't this patient up? If they're alive, they have to be up. And that goes into program sustainability, right? So we track falls, we track CLABSI, we track CAUTI, we track HAPI, we track all of these like hospital improvement, clinical quality improvement numbers and all of that stuff. And mobility needs to be tracked. Mobility documentation and compliance needs to be tracked. And the reason CVICUs are so successful in mobility is because the surgeon and the MP are checking the mobility score at home from their cell phone. I have gotten texts from surgeons at 6 in the morning, 7 in the morning, how far did the patient walk, when I've just opened my eyes and haven't even gone to work yet. And so making sure that there is a quarterly report of internal data tracking showing mobility documentation. Are we documenting mobility? And that will really uncover if nurses know where to document mobility. If mobility is even built into your EMR, does your Epic have a section? Does your Cerner have a section where mobility is even an option to document on? And that will kind of ensure, going back to step one, that you're meeting your program goals. If you've set a program goal that every intubated patient has to reach a mobility level 3 before they're extubated, how are you going to track that? If you're not tracking, extubation is logged in the flow sheets, mobility is logged in the flow sheets. If you're not tracking that, but you're saying, we mobilize, we get patients up, like Haley said, that might be Hoyering on day 8 of trach when the goal was sitting edge of bed before extubation. So a program's not going to be sustainable or successful if you don't have a way of doing like a quality check and tracking and having an enforcement system for maintaining those goals.
But that may not be an option.
Yeah.
Often, like some of like the participants' facilities, they may not have tools like implemented into their EHR to allow them to track. So right now, I find a lot of hospitals have BMAT, bedside mobility assessment tool for the nurse, which is supposed to be like what level of mobility is performed and what they're capable of, but it doesn't really capture what they actually perform. So it's basically like in bed, bed, sitting, walking. That's it. It's super basic, and it's supposed to help them critically think through what piece of equipment. Okay, so that was implemented years ago, and people were like, yep, done, check. But then I asked, what are you actually performing? And they can't actually track it. So then you need another tool right now, probably the best that's out there is Johns Hopkins' highest level of mobility.
Yep,
It's
HLM.
very user-friendly, and that actually captures what mobility was performed. So then we can look at, on average, what's the timing of mobility from admission to initiation of mobility, and what levels of mobility are being performed on average. When I have teams do manual audits, we look at that to say, what's the timing, what's their baseline, what's their level when they leave the ICU, and then and what do they perform in the ICU. And I like to take that HLM and put everything together and be able to be like, for example, one team to say 40 or only 40% of your functional baseline, no contraindication to mobility patients actually got gravity during their time, during those 10 days. 60% did not get gravity because this specific team was very confident that they did an early mobility program, that PTs and OTs go to the ICU, but primarily because of the timing and the sedation practices, they did not get actual gravity. So it's really important to capture what are we performing as far as the level, the dose, and the timing of mobility. But most teams right now either don't have it or don't consistently and accurately use it, and they don't necessarily have a way to pull it. So even teams that have all of this stuff, like one team I trained, they had way too much mobility documentation. Like it was excessive, repetitive. And then I said, okay, well, show me your dashboards. And they're like, we don't have any. So they're not actually utilizing that data at all. So when you use a tool to capture what is the patient capable of, what are they performing, what's their goal, then as a team, like even in Epic, you can make a live dashboard to look at what's their BMAT, what's their HLM, so that you can quickly look through who's appropriate for what. And that's a huge barrier when you're looking at resource utilization, is it takes so long. If you even have a mobility tech or a resource nurse looking at that, they're like overwhelmed by this 26 patient ICU, and they have no idea who's appropriate, what the goal is, what we're doing. And so if you have a way to utilize what you're even documenting in a live tracking kind of setting, as well as being able to pull the dashboards in retrospect and be able to track your current status and progress, that's what we're working towards. But most teams may not even have like an HLM implemented already.
Yeah, and that goes, I think that's one of the most important elements of having an early mobility program is, and this is why you start with presenting to your rehab leadership team, is in that presentation, you need to emphasize the importance of adopting standardized outcome measures, including like a nursing mobility screening algorithm, highest level of mobility, medically appropriate criteria, RT protocol. So all of these already exist, by the way. You don't have to invent them. I think that's a huge thing that hospitals get freaked out about is, well, we don't have it. How are we going to start it? What are we going to do? And all of these things already exist. There's so many out there. You just need to adopt it for your institution and tweak it a little bit. And having these measures in place, like Kaylee mentioned, if you don't have a mobility measure that tracks the highest level of mobility performed, how are you going to audit that? So that's why it's important when you're starting at step one, part of your presentation to your rehab team is explaining to your managers, and this is not for a staff therapist to do, this is for leaders to do, of adopting these outcome measures and reaching out to other hospitals and asking, hey, can we use this? Can we use that? And that way you can track your success and track sustainability with data tracking.
I think another important thing to track is like a sedation report. So being able to pull from pharmacy what sedatives are used, which patients they're used on. Dose is tricky because you can have certain patients that just require higher doses and can throw everything off. But over like a year span, you want to see that use plummet. And that's really helpful, especially when you're trying to make the goal of we're only going to use sedation when there's an actual indication.
Absolutely.
And right now, and ask your team, your leadership, if you have an ABCDEF Bundle dashboard. Because again, that's more things that are being charted they don't necessarily utilize and review. But that dashboard is only looking at compliance with charting. So across the board, nurses can screen for early mobility. That E will look perfectly compliant, but all the screenings could say bed rest. So that's where they're at. They're like, yeah, we screen for mobility, but they're not actually executing it. But same thing with awakening trials. You could just chart awakening trial. They start to like twitch and they turn sedation right back on, but they chart awakening trial and it looks good. So that's why a manual audit before you implement, while after implementation, to see to really look at objectively, is our charting actually accurate? And then look at
Exactly.
that charting.
And I totally agree, because that also helps with the biggest barrier being sedation practices for us is, tracking, like PTs and OTs, we also document RAS. And a lot
Good.
of times,
Not everyone does.
our RAS and the nursing RAS does not match up. We've heard from therapists a lot that when we put in the RAS, we look and the RAS documented 5 seconds ago is a very different RAS than what we wrote. And this is why doing an audit is so important, is that same survey of the nurses and doctors and RTs attitudes and beliefs on early mobility. What you may have nurses completing of, yes, we mobilize, we're great, we don't have problem with sedation. And then a PT that has been working with that nurse for 10 years writes, nope, we're not mobilizing, sedation's a huge barrier. And then looking in the chart to see what was documented for sedation and what was documented for arousal, this takes that huge burden off the shoulders of the therapist of constantly getting in trouble for advocating for sedation or being too pushy, practicing outside your scope. These things will be discovered by managers, who are the people who are responsible for tracking these things. A staff therapist shouldn't have to take this heavy weight of being the one that implements the entire bundle and ensures compliance. It's not your job to make sure nurses are adequately managing sedation correctly. That's the job of leaders, and that's the job of physicians. And so at the end of it all, tracking helps with a lot of things. If you're not tracking progress in any realm of life, you're not going to know if what you're trying to implement is successful or not. Thank you all so much to our amazing speakers for being here today. We went a lot over, but I appreciate you all being here on your lovely Saturday and talking to us about how to start an ICU early mobility program. All of these resources, whatever was not already on the website, will be on the website by the end of today. And you guys can send me and our speakers any other questions you have in terms of like consulting and just overall mentorship. So thank you, everyone. Have a great day.